I think we're going to move forward with Tish Poe and ultrasound's role in the diagnosing deep venous insufficiency and treatment options on the horizon. Is Tish still here? Oh, gotcha. I see you. All right, talk amongst yourselves for a few minutes.
We have one more giveaway. We'll go ahead.
Okay, let's do that then.
I'll let Dr.
Do I get to
Ford
pick?
point out.
Yeah. What's it for?
It's for the, right there, the prize right there.
I'm going to the bottom.
Okay. Misty Hernandez? Yeah.
Come on down. So I had a flashback when Tish called me out back there when I was looking down at my phone. It was 20 years ago, and I was her fellow, and she taught me how to do ultrasound many years ago. But I had just a momentary flashback. But I was doing very important things, by the way, Tish. I was working. So okay.
But I needed you to comment because that is a big point. Do you measure residual or not? And I've had people say yes, no, and maybe. So yes, I know I pulled you out of the middle of things, but
I got the answer right.
You were perfect. Yeah. Okay, good. Now that we have that out of the way. And I wasn't a spring chicken when I taught him, so yeah, that's, yes. Just stand up straighter, right? Okay, venous reflux. Let's talk about this, and I'll tell you that I had, with the exception of transcranial Doppler, I think I'd done pretty much everything for all the years in lots of measures. But in the last 2 years, myself, Kayla Weisekel, who I'll point out over here, is also part of the clinical team at Invino Medical. And right now, everything that we do, when we talk about what we know, think we know, and don't know, I always say so far. And I think Kayla would agree with that, right? Because there are a lot of things that we think we know, and I'm going to talk a little bit about that and try to get you through this fairly quickly. But it's been an intense area of research, and having been probably more on the arterial side, which has been, as we've seen in some of the other talks, the bulk of our work for a long time, and as veins have come on, and now I'm going to more advanced vein meetings. What we don't know, and what we're seeing in our research, what we don't know weighs me down every day and keeps me up. All right, so what do we know? And Brian went over this. I am not going to spend an awful lot of time on the anatomy. We've mentioned the SEEP classification. How many of you understand and use SEEP classification language in your labs? How many of you don't? Don't really use it? Okay, well, we need to understand again what the physicians are saying, and we know about venous insufficiency, and our work has been in the deep veins primarily, so I'm going to focus a bit on that. But is that valve dysfunction creates this insufficiency and changes that whole pressure thing. So, and the duplex is a great way to work patients up for this. Okay, very great way. So just the anatomy, we know it. We know that arteries are different than veins in terms of the thickness of the different layers of the wall. We also know that veins come with valves that are a bit of the endothelium that form these valves and are just kind of just amazing structures. It's not, to me, how often they fail, but how you can go so long with not having, most people not having the most advanced venous disease, because we stand up every day and we put pressure on them. So again, I am not going to go through these because there are more important things to cover, but I encourage you, like every topic we have talked about, that you know the anatomy and that you know the terminology and you know where things are supposed to lie, although veins are very devilish, aren't they? They kind of do their own thing many times. When we talk about the superficial system, this whole thing of the terminal valve and the saphenofemoral junction, it's not just the terminal valve, but down to the pre-terminal valve that is really part of that saphenofemoral junction and possibility for where reflux starts. And again, this is going to be more about some of the advancements and some of the things that we've seen. And again, what I feel so strongly now, I don't know anymore. So we need to know the anatomy. We need to know that at that saphenofemoral junction, there are a whole lot of other veins. and this leads to sometimes helping after an ablation to keep flow going through there. It can also be the next source of reflux. As we went over with the anatomy part of this, we know a lot about this now. We know about perforators. We know things that we didn't have to know when the whole venous world was rule out DVT. And I come from that world where that was basically what we did. And now the valve assessment, how much you do, what should you do, and knowing that these things are all connected and also have companion lymphatic systems that are another part of things. That's why the professional group is now the American Venous Lymphatic Society, AVLS. We also know that in the superficial system there are a lot of tributaries that you can, accessories that you can expect. The diagrams and normal anatomy always show you what should be there, and our job is to find out what is actually there and how big they are so that can we see them? Are the varicosities of saphenous or non-saphenous origin is one of the primary questions that we need to answer as well. So again, this first part is know your anatomy, know the many variations. Here are some, but I'll bet somebody out there has something even different from all of this as far as how the small saphenous vein actually connects. Does it go into the gastroc? Does it go into the popliteal? Does it go up the leg? What is the point of reflux? Where should you fix it? How can you fix it? And that's the superficial. But we've been working on deep vein insufficiency, and I will show you at the end of this a device that we're hoping is going to help more patients. We're hoping. But the deep system is also highly variable, and I think Brian did an excellent job of going over this as to how things connect and embryology formation of these. How dominant is the profunda? We ignore that deep femoral, don't we? We just ignore it most of the time. There it is, it's open, move on. But it has a big role too as to where it connects and how it connects. So I'll go back to what I did kind of a bit in the first talk I gave. We need to look at B mode. We need to look at the anatomy and understand that when you find, especially with these veins, here's a vein, but it could be an artery too that we're looking for in those types of scans. Here we think it is. If it is that thing, it should follow this certain pathway so that you really lay out what you're seeing. And we can see a lot. Where's the small saphenous? Where does it go into? We can lay out for physicians, okay, we have a saphenous in the fascia. So in the fascia, and and I always get this mixed up, on the left side of this screen, on the right side you see a vein outside of the fascia, or what the first time I saw somebody write oof, I'm like, it's a what? Oof, does anyone else use that? Oof, out of fascia? Yeah, but I looked at it and said, what are you trying to tell me there? So, out of fascia, but then we can also show it crossing the fascial plane in a long axis view. We can tell them a lot about what's going on and do every day because superficial veins have many pathways for treatment. Okay, now let's talk a moment about the deep veins. So as we look at the deep veins, it's very easy to sometimes miss a second vein. It's very easy to call every femoral that looks to have two a bifid system. And if there's one thing our group's been doing a lot this year, it's reading a lot of papers and research and looking at all of this. This could be bifid. It could have formed a larger vein because there is chronic material in that one of the two veins. So you want to look carefully, and you want to see that it compresses. And it compresses into what we would call a chronic scar. We really encourage people, I think, from SVU and from other organizations to say, stop saying chronic DVT and say chronic scarring. It's no longer a clot anymore. So that's that little issue. So where does reflux come from? Again, genetic valve malformations, you can have a family history of, but a lot of patients develop the chronic venous insufficiency that advances their SEEP classification from 80% of patients have some sort of post-thrombotic syndrome. Pressure overload, as was said by Dr. Lazar. I mean, this is a pressure type of scenario. Where's the pressure? And we know things go from, they seek out a path of low resistance or lower pressure. You raise the pressure, you change some of these hemodynamics. Valves are important. That calf muscle is very important. And because I go back so far, I often refer to people about physiologic testing, and that's something that as well, we may find reflux, but just like you find an arterial lesion, what does it mean for the area distal to that? So this is a video I made quite a while ago, and when I play this, I've watched this for many reasons, different times in different presentations, but we know a couple of things as well about the anatomy, in that the number of valves increases in the deep system as you go further caudally toward the foot, distally. Another terminology that's been used more is centrally and peripherally. So as we've heard from other people, and as I really, really would like to see before I actually stop in this field, is can we get some common language? I mean, cranial caudal, I like, and peripheral central is being used by some groups, but in your lab, understand what people are talking about. But as you watch this, we can actually see in the deep femoral, this is the femoral vein, no longer called superficial. This is the deep femoral, and in this one, there's a patient lit up like crazy, right? We can even see a little artery in the flow divider here. I don't know. This was like one of my favorite videos ever. But also watch through that profunda valve. You can't see the valve in the femoral vein, but we can see this one very clearly. We see that kind of flow or the cells gathering where you have brighter reflections in the valve cusps. But watch through this, because as we've been reading more and more about valve function from a number of very wonderful authors and researchers, it's not just a straight flow. We don't talk about laminar in this very much. It's a helical flow pattern, and that's been shown. Dr. Lurie has done a lot of work on this, but watch how this gathers and how it goes. There's also a flow like a jet. Once the valve opens, there's a narrower amount of lumen. As that valve opens and closes, it's not like, and I always liken this to a door. You know, if I wanted to close the door back there, it takes some time for the door to close. If I don't give it enough pressure against it to close it, it's not going to close. So this is a key point to think about when you're doing reflux studies. If you're getting reflux within an amount of time that's been, you know, a number. I always say numbers are so sexy. You put it down, it's like, there's real data. That has to be true. It's a number. And that's great. But is it a number that makes sense? Is it a number we should really be attracted to, or should we question it? So they don't open all against the vein wall. Flow is helical. So how does blood move in the venous system? Valves, respiration, hydrostatic pressure, and calf muscle pump. It could be some other things too, but those are kind of the big four. And again, from Dr. Lurie's work, we've actually had conversations with him, and he is there at the Jope Center in Toledo, Ohio, which is where I grew up in Toledo, Ohio. I passed that area all the time when I was a kid, so it's been nice to reconnect with them there. So, opening phase, we have an opening phase, we have an equilibrium phase, and each one of these takes time. Now watch at the equilibrium phase as the valve is opening, and then as it starts to close. These are thin structures. There is fluttering. There is a jet that goes through there to some amount, and then you have a closing phase, and you have the closed phase. So just like closing a door, it's not like it's open, it's closed. It has some time that needs to happen, and some of it depends on the force we use against it. So here's a beautiful picture of a small saphenous vein with an augmentation and a reflux waveform. Spectral Doppler is how we document this, not just by looking at the valves, and they'll tell us a lot. Take color off. I've said it once, I've said it a few times, but take color off and look at the valve motion. Look at the valves, look at the vein walls. Color's very helpful, but it's not always necessary. Change the sweep speed. You can see things better, and the scale, so that you can see what's happening. And if you notice in this, what's different from how I did vein studies for a long time until I changed, as I have done many times in my life, in many ways, is that you have the popliteal with a non-augmented signal that is respirophasic, but the sample volume is open wall to wall. Now the sample volume has a dimension, and it also has kind of a cubic dimension there. As Brian was talking, and as I've done before, chasing that, oh, there it is, right? There went that little red thing of reflux. There went that velocity thing. Open it up. We are not looking at laminar flow. The peak systolic, or the peak velocity, will be the peak velocity no matter what, and we don't care about spectral broadening in a vein. Open it up and take a big bite out of that flow area there. We put the angle correction in, which you don't have to do. You still have to be at an appropriate angle, but we want to be able to see what happens there. And we are measuring certain velocities and things. So, SEEP classification, which again, you can look this up. If I read this to you, you will remember it no better than if you print it out and put it on your wall and you look at it every day. But there are SEEP classifications that SEEP is, the C is clinical signs. They've added a 4C, which is the corona phlebitica, and that is down at the ankle, and I show you a picture so that you can see what that is, paraplantaris. E is the etiology of this. So etiology, again, is it congenital, is it primary, is it secondary? We can't tell, but it's patient has it. So etiology is the E, and you should know this so you can speak the language with all of the providers and interventionalists. The A is anatomic, superficial, deep, perforator, okay? P is the pathophysiologic part of SEEP. So was it reflux, again, is it reflux alone? Was there obstruction, thrombosis? Is it both? So know what it stands for, and I would print it out and put it on the wall. The more you speak it, the more you will understand it. So here are some things that we think we know in every one of our labs. We think there are standards, and the ones we use are the best because we're using them, right? That's our standard, whether it's carotid criteria or whatever else. But we think that there are standards that are even more precise. Patient positioning. We think that the way we're doing it is the best, and that we all use some different things. Sitting, reverse Trendelenburg. Unfortunately, I've been assigned to rooms at times myself where here's a flat table. Your next patient, and I mean a flat wooden table, your next patient is for reflux. Oh, not going to work very well. The settings on the machine. You must know how to play with those. And Terry Needham was a dear friend of mine, a chum, as he called me and I called him. And yes, he taught us all to be a little more careful. And we think we know that the reflux time measurement is the most important part of everything. Okay, so let's talk about flow reversal. And in the supine position, your patient is lying down flat or fairly flat. We know we've already been talked to about the increase in pressure when you stand up, hydrostatic pressure. The flow goes up, it comes down. When a patient is laying flat, there is no ability. What's going to close the valve? There's no force on that valve. It's just kind of, it's just there. So this is not good, and it does matter. So if you say it doesn't matter what position you're in, as long as you get that magic number, it does matter. Because if you don't challenge it to close the door, you're not going to have anything happen that is going to be anything but a false positive, possibly. So it does matter. Now, we've all used this. This was made by Nikos Labropoulos and his group. Back in the early 2000s, there were a lot of research and things that came out about this. So here was, again, what do we like? We like those numbers. We want to have a number to hang our hat on. And so do the insurance companies, right? So these numbers are out there. And you must know that these were created in the standing position, just like with the carotid criteria. You can't take one from column A, one from this person, totally disparate kinds of ways of getting that criteria created and just apply it because it's convenient. It was created in the standing position, okay? And why stand the patient? Because when you have, and this is from Sarah Skonsberg, I appreciate her slides. We all share slides now in our group. And so why stand it? Because again, you want to close that valve door if it's going to close. Gravity is going to pull it this way. Supine's not great. Now we're on a reverse Trendelenburg. Gravity's pulling it this way. Still not optimal as this would be to, again, close the door. That when it goes up and gravity pulls it down, you have hydrostatic pressure, you have changes in pressure, and that should allow the flow to have enough force to close the valve. You need consistency. In all the meetings I've been to where you look at appropriate use criteria, sometimes the recommendation is way up here and the level of evidence is way down here, and I hear over and over and over again, we can't even compare one person's type of research study to another because everyone seems to have their opinion about how to do this. So, why stand the patient? All of the reasons I've said. You have to have enough force to try to close the valve. Otherwise, you're giving someone a disease they don't have. Closure time can take generally less than 0.5 seconds, which is why that 0.5 for superficial, 1 for deep, but some people use 0.5 for a lot more things. And that again, it takes about 30, it's been an estimate. These numbers go out there and they stay in our vernacular forever, right? So it takes 30 centimeters per second, reverse flow, to close the valve. So where's the debate? Certainly not here. Supine, flat, no, don't do it. You're not going to have valve closure being tested. You can do it for ruling out DVT, but now the debate is, of course, this. And as I've worked in this more, and I've done a lot in reverse Trendelenburg. And then we have those do it in reverse, but if you don't get it, then stand them up. I'll address that a little bit. The other thing is augmentation consistency. Valsalva has only been shown to be effective at the groin level, period. You can't keep asking the patient to Valsalva. You might get some reverse flow, but again, we have to have consistency in method, or how you do something and how I do something, from the carotids to the veins to everything, is not going to be comparable. You need to get the calf muscle. So an engineer at our company was with me on his first visit into a vascular lab, and high-level place, the technologist reached down and squeezed the tibia. That is not squeezing the calf muscle. That is not what ejects the blood. And you can't drop the probe and give it a little bump. You can't kind of, so, especially because we're looking at deep veins. So if you need an assistant, you need to do that. And you need to hold it for 2 to 3 seconds. We are deployed out to every research study, not to direct what happens or the numbers that are produced. A lot of times we are professional calf squeezers. That's how I live now, okay? Or you can get one of these, because telling someone to squeeze a big calf and hold it for 3 seconds or 2 seconds while you're controlling the probe and the machine and the patient's, we are a second person there. That is not affordable in most labs, but we got to think about what we're doing. So clinical experts think that all of this upright position and all that's appropriate. Again, to incentivize, this is a list from the American Venous Forum as appropriate use for ultrasound. One of the things that as you go down this list that I don't read to people, I expect you're looking at it, and you can have my slides anytime, but the incentivizing technologists, and I have seen this, if you find reflux, this person finds it more than that person, they're more valuable to me, because all they have to do is hit that number, I can treat. We all know it happens, and it's not right. So let's look at this. So reflux time. Anybody can place cursors just like we did with the aorta, right? These are from real studies. So we look at this one, and for those who don't know, we have an augmentation maneuver here. Calf is squeezed, held. Here's the reflux. And it was measured like this. Everybody think that looks good? Don't be shy. Nod. That looks pretty good. I like it. How about this one? This was probably a Valsalva because I see no augmentation and it's at the popliteal level. Let's see how this one was measured. Right here, if you can't see the little cursors, right here. Oops, I'm sorry. And what's the rest of that? What was the impetus to close the valve? I don't know. I don't think that looks very acceptable for data. How about this one? It went back and forth and back and forth. All right, so where did they put their cursors? Oops. Okay. All right, how about this one? Where do you put your cursors? This person gave them a whole lot of reflux. Back and forth, back and forth, back and forth. That's not a consistent reflux waveform. And this one is much like that first one. Okay, right? We're back. We're back. Do you agree? Here's one. Oh, there's two. Okay? But this is what people are treating off of and how you're comparing post intervention. So, my last 5 minutes or so. So what we don't know is mounting in my poor little brain at this point. What really matters? What matters? Reflux time? I think it's real important. There is reflux. But how do we standardize the exam? How do we best test for this or test the patient or assess the patient for success or failure of a procedure? How can our sonographers, and this is one of my main ones, be protected from the repetitive stress injury that is going to happen? And they'll look at me and say, please, Tish, don't say standing. Please, don't say it, you know. And it is the position to use, but you need the right setup, equipment, and time. Now, if you think there are standards, and this is impossible to read possibly, but you'll have it, at the bottom are abbreviations. Every group defines what is a standard way or a recommendation for this, including standing. A little reverse Trendelenburg, 15 degrees, or a lot, or you have to stand. AIUM says 45-degree reverse Trendelenburg, upright, semi-upright, maybe laying down, maybe squeeze, maybe hold, all of this. So what people look for is the number. So here are my personal recommendations from the things that I've seen and what I know. And again, I always qualify it to so far. This is what I know so far, and I am willing to change because I've had egg on my face a few times in my career as to what I should be doing. Document the degree of the bed tilt. Open the sample volume. Why are you looking for small center stream flow in a reflux waveform that could be going all over the place or around? Open it up. You may not have to measure the angle, but we may be looking at velocities in these at some point. Hold the augmentation. You cannot do a, that is not just pop. No, hold it like you do when you squeeze the calf muscle. Valsalva is not appropriate beyond the groin. Whoopsie, sorry. And we need more research. Good grief, we need more research in this. A lot. How do we assess it? How do we tell if what we did works? What degree of reverse Trendelenburg is equal to standing? If you're going to say standing, but it could be reversed, what tilt should we use? And again, how to best treat CVI. How do you best treat it? There are compression therapies, obviously, interventional procedures for the superficial system, lots more being developed for the iliacs. There is nothing for the deep veins in the leg itself at this point. Endovenous therapy, surgical management. There are some people who will treat, like band a popliteal vein or whatever. There are some people treating deep veins, but it's fairly rare at this point. So this is the concept that came up that we're testing. This is not an approved device. I have nothing to sell anybody, and neither does the company. So there were 75 patients that were implanted with the Veno valve, and I'll play the first one. This is a model in a laboratory, so a lab model of how this works. A stainless steel cage with a porcine non-coronary cusp of the aortic valve and a bit of other tissue from that porcine heart and aorta and mitral. Here it is with another thing. So the concept was a unicusp valve that will open and close in this cage. This, the first trial, Savvy, if you want to look it up, was surgical anti-reflux device, surgical. This is what it looks like, and the design was made with a prosthetic device that is meant to have a really good, it takes 700 pounds of pressure to collapse that, okay? So you're not gonna be able to compress it. This is what it looks like with one of our co-workers holding up a plastic model in front of the screen. There are 75 patients with this. We've already had some people like, oh, you know, your patient, you know, we now found out that there's DVT in that patient, in that the valve's not open because they couldn't compress it. With color flow all through it and a Doppler signal that is phasic through it and no signs of clot above or below, your patient has DVT. No, compression's important, but not when there's a stent in there. If you see something that looks like it shouldn't be there, then say, what is that? Is that an endograft? Is it a this or that in arteries or aneurysm? You see something like this in a vein, you shouldn't just say, oh, there's a vein. You can actually see the little bump out for this valve sinus. We can see the crossbar in some of these images, and sometimes it's going to be harder to see, but if it doesn't compress and there's full color through it, and it may not be what we're working on. There are other people trying to devise. Nothing's gotten close to FDA approval. We're close. We don't know. Close is not, no cigar yet, right? So know that things are happening and that you should question what you're seeing. And the goal is to take a person from baseline to 6 months, and we're following them. All of our patients now are at 2-year follow-up times. But we're working on this because this type of disease takes away people's, many times, their job, many times even their relationship, their ability to play with their children. And we hear all the stories that are success stories. People love to tell you those, right? And we have people who have had issues. We've got to sort out why they're having issues. But people who say, I walked, past 3 baseball stadiums to my granddaughter's baseball game. I hadn't been able to do that before. I can play soccer with my son. I walked 3 hours around a city with my husband, never been able to do that. So, anyway, that's what we're looking for. Now, one word about ergonomics. This is what I really don't know, why this is not a top priority in every vascular lab setup. You need the right equipment to do this without hurting yourself. You should not have your arms suspended in weird positions. You should not have your patients in a compromised position. You may need, if you don't have an assistant to squeeze that cap, then I think you should have a compression, a rapid cuff inflator, RCI. If not, if you can't get your hand around it, saying, well, I gave it my best shot, isn't going to tell you what's going on. So get the right equipment, be able to move it, to tilt, to turn, and to have people who are maybe as tall and long as me or as short as some other people. Kayla and I are different sizes, and so we need that. But thank you very much, and I want to thank Vic for having me back again this year. Thank you.
Thank you, Tish. Lots of good work going on with the vein world. And we won't talk about standing versus reverse Trendelenburg, but I do hear what you're saying, and it's very relevant. So we're going to switch gears a little bit and talk about other veins. The ultrasound role in dialysis vein mapping, the old and the new. So just a little bit of statistics. We're talking about vein mapping for pre-op eval for dialysis creation for patients with chronic kidney disease. So the National Kidney Foundation published some of these statistics. 400,000 patients are treated with hemodialysis yearly in the U.S., and Medicare on average spends about $90,000 per patient per year of treatment. So the KDOQI guidelines recommend autogenous arterial venous fistula first, then prosthetic grafts, and last hemodialysis catheters. So what is the purpose of the vein mapping ultrasound? Well, it's to identify suitable veins for grafting or cannulation. It's to give that vascular surgeon the information he needs to create the best dialysis creation for that patient. So we're looking for thin, compressible veins that you can follow them in continuity. We are assessing for vein patency, vein size, and location of the vein. One of the most important parts of this process is patient prep. So you want to explain to your patient what you're going to be doing. I'm looking at your veins to see if I can find, usually I tell my patients, I'm getting the sizes of your veins so I can tell Dr. Lassar which veins, how big they are, and whether or not he can use them to create your access. Get a good history, any previous vascular surgery, prior dialysis access. Are they on dialysis yet? Are they using a central venous catheter for dialysis? Have they ever had any access creations in their arm? The most important part of this to me is the patient, the room should be warm, and both you and the patient should be comfortable. We've talked a lot about proper caliper placement in everything that we do, whether we're measuring a stenosis, we're measuring an aneurysm. But in order for you to get the best data for the vascular surgeon, the patient needs to be comfortable and you should be comfortable. Typically, I will have the patient, I put a pillow on my lap or on the bed so they can rest their arms so they're comfortable. I'm comfortable because if I'm not comfortable, I'm not going to get accurate vein size measurements. If the patient's not comfortable, we're both going to be there a while. In our protocol, we always evaluate the central veins. It won't necessarily take that patient out of being considered, but it's information that the surgeon needs to know from your vein mapping, whether or not they have some type of outflow obstruction centrally. So we always evaluate the subclavian, the nominate, the internal jugular, axillary veins centrally. You're going to follow the veins on a transverse view with grayscale, dual screen documenting patency of the vein. Again, we're looking for thinly walled, compressible veins. We also evaluate the arterial system because you're creating an access between an artery and a vein, and so you want to give that patient the best possible outcome. So the more the vascular surgeon knows about what's going on in their venous system and their arterial system before he does the surgery, that's going to be the best outcome for the patient. We do diameter measurements of the arteries, document waveforms, make sure there's no significant stenosis. We also do pressures and evaluate the palmar arch. So technique. You want to get the best possible images, transducer perpendicular to the skin because you're getting good grayscale. You're not taking a Doppler, but you're getting good grayscale images. You want to be able to see those vein walls measuring inner wall to inner wall. Keep that vein evaluated in the center of the, being evaluated in the center of the screen. Measure AP, internal diameter and transverse, about every 3 to 4 centimeters. If I see a large branch coming off, I take a measurement above, and then once that branch comes off, I take another measurement of the vein. being careful not to compress the vein with a transducer. So you have to have a light touch on these patients and use a lot of gel. I get ribbed a lot at the lab because I'll use a lot of gel, but I get great pictures and I'm really quick. So that's what I tell people when they come in. Tina, you used a lot of gel. I could move quick. I didn't have to take the transducer off the skin because I had enough gel so that I could move down the arm or down the leg. And I had enough gel as a standoff so that I could get good round measurements on that vein and be able to measure it accurately. So we measured the superficial veins in the arm, cephalic and basilic, using a tourniquet above the area that promotes venous filling of the vein. Again, patient's arm should be relaxed, slightly abducted away from the body. Support their arm either on the bed beside them or on a pillow so that they're comfortable and relaxed. As I'm doing my vein mapping, then I'm going to note any abnormal findings, a frozen valve leaflet, any thrombus, any bifid vein, large branches. All that's important in your vein mapping to give the surgeon as much information as he can to plan that best access for that patient. So when you're interpreting your vein mapping, there's a lot of variation in veins, and particularly the arm, so you need to know the most common variations. I think one of the most common variations that we see is probably the takeoff of the basilic, and sometimes you'll have the radial and the ulnar a high bifurcation above the elbow as opposed to just below the antecubital fossa. So you need to know those common variants and comfortable with the interpretation of that. So you're looking again that there's a healthy system present and whether you can follow it in continuity. Pretty standard. Most publications and vascular surgeons want that basilic or cephalic vein to be at least 2.5 millimeters in diameter, thin-walled, easily compressible. So just quickly talking about surgical outcomes because we are talking about the old and the new. So traditional open procedures would be your arterial venous fistula, arterial venous graft, or venous catheter. And now we have new endovascular arterial venous fistulas that we can create in the office lab. A surgically created AV fistula, the benefits, there is a significant decrease in infections, hospitalizations, catheters fail, develop central venous stenosis, significant decrease in mortality and overall cost. That's why KDOQI guidelines came out with fistula first. The rule of sixes is often referred to when assessing the maturity of a vein after a arterial venous fistula has been created. Usually it takes 6 weeks to mature. You want a flow volume between 500 and 600, diameter of at least 6, and it also has to be superficial enough so that when they go to dialysis to dialyze that they can actually cannulate that vein. So it needs to be a depth of 6 millimeters or less. Different types of AV fistulas, surgically created, radiocephalic at the wrist, brachiocephalic in the upper arm, or a brachial basilic transposition. So that basilic is usually deep, so sometimes that vascular surgeon will do it in 2 stages, or they'll create the brachial basilic and then they'll bring them back to elevate it or transpose it. Just a few images of what we look at. Post-creation, when you're evaluating the AV fistula, of course we know because it's a fistula, there's going to be one anastomosis, either the radial artery at the wrist or at the brachial artery, if it's a brachial cephalic or brachial basilic. So you're going to evaluate the inflow to that fistula, the outflow vein, and then the confluence at the native vein. Opposed to, so now the next, if the AV fistula, if they weren't a good candidate to create an AV fistula, maybe their veins were small or non-existent, so it left that surgeon with creating an arterial venous graft. So you will either see a straight graft or a loop graft. I tried to get pictures of both, but basically there'll be a loop, artery to vein, or just a straight graft from the brachial to usually the axillary vein. So those are your surgically created fistulas. We also, in recent years, have the option to create an endovascular AV fistula. There are two similar yet unique devices out there now, Wavelength and Ellipsis. They both have, I think, some pretty good data. We currently are putting Wavelength in our lab. We didn't have good, we did not see a lot of patients who were candidates for the Ellipsis, but there seemed to be more patients who are candidates for Wavelength. But that's over my head in another talk. But what are the advantages of an endovascular AV fistula? Well, they don't have to go to the hospital for this procedure. They don't have an open surgery. It's minimally invasive. We can do it in our lab. You don't have to use the non-dominant arm. The patient can use their dominant arm. They don't have to recover from a big surgery. The fistula results in shared flow between all of the outflow, the basilic, the cephalic, and the brachial veins, because the upper arm vessels all receive blood flow from that anastomosis that's created in the forearm. But both depend on a good perforator, because you're creating that fistula at the radial artery, radial vein, ulnar artery, ulnar vein, and I think the ellipsis is to the perforator. So either one, you have to have a good perforator. So a good vein mapping is essential to getting that patient the best surgical treatment. And so you need to take your time, do a good study, make sure you're measuring, make sure you're following the veins. The superficial and the deep system communicates via that perforator in the forearm. So if they have a good cephalic and a good basilic in the upper arm, then you know, okay, now I'm going to go down to look and see if they have a good perforator. If that might make them a candidate for one of the endovascular options. If they don't have a perforator, then the surgeon knows, okay, I could still create a good fistula in this arm. It just won't be an endovascular fistula. So open versus endovascular, which one should you use? Of course, that's up to the surgeon. The one's more invasive, requires incisions. The endovascular is minimally invasive, catheter-based. Recovery time is longer with open surgery. An open approach may be preferred for somebody who has difficult anatomy, and endovascular is suitable for less complex cases or when direct access is not required. So they both have pros and cons. So the preliminary data suggests that the arteriovenous fistula may offer superior primary patency rates, lower intervention, and possibly lower overall costs compared to surgically created AV fistula. But further prospective and multi-center randomized controlled trials are needed to further characterize one over the other. So my final thoughts, the vein mapping plays a crucial role in creating a successful dialysis access. And I can't overstate that enough. Both open and endovascular approaches have specific advantages and limitations, and the choice of technique depends on the patient's anatomy. They have to have a good, healthy 2 millimeter perforator to be able to create an endovascular AV fistula. With advances in technology, vein mapping is becoming more accurate, less invasive, and more patient-friendly. And this is my last slide of the day to show my dogs. I showed my daughter's dogs, my happy place, and now these are my dogs. Thank you.
So Tina got us down to within 1 minute of the time to end the conference. She did it. Thank you very much. I appreciate everybody's efforts. Learning is painful. Okay, that is part of the process. I hope that the lectures today made that as painless as possible. But I think we had some great topics and some good conversations about ultrasound and vascular disease. And I want to thank all the speakers for their efforts in putting together their slides and helping to educate everybody. I want to also thank Marriott and the company. They did a great, excellent job. I'd like to thank Six Strong for our audiovisual, our sponsors for putting everything together. I think this ends the lecture portion of this program today. We still have a breakout session, 2 sessions, one with Deanna and the other with Abigail on pelvic vein evaluation and then tibial mapping for PATs. So I think that's ongoing now from 4 to 5. At I think 5 to 6, there's a reception at the restaurant downstairs, the bar area. I forget the name of it. It's the Tennessee something or other. Tennessee Room, thank you. And then following that at 6 p.m., there is a dinner didactic by myself and Dr. Harris. I think people have RSVP'd for that. If you are looking for additional spots, just come and find Carol Malone. She raised her hand back there, and just let us know what your needs are. But thank you all for your attentions, and I think it was a great conference. If you are staying for the vascular portion of the conference tomorrow, that's going to be kicking off same place, 8 o'clock, and then I'll see you then.